Hello and welcome to all of you. In this video, we'll talk about this general pharmacology. So we know that general pharmacology, we have the various aspects. The first aspect is drug absorption. So we know that the drug absorption is best calculated by the area under the curve. So drug absorption is also known as bioavailability, and this is best calculated by a graphical parameter. We call it area under the curve. So what are the various factors which can affect the drug absorption? So if a drug is more lipid soluble, the drug has more bioavailability. The size of the molecule is less. It means the molecule can easily cross the membrane. So more is the bioavailability if less is the size. More is the size, then the bioavailability is going to be less. More is the surface area of the absorbing surface. More is the bioavailability because more number of molecules can be absorbed at a time. More is the vascularity of a surface area. More is the bioavailability because more blood will take away. More blood will take up the more drug from the membrane. So more is the vascularity, more is the bioavailability. Now, if the medicine is taken after food, the medicine absorption gets slowed down. So when the medicine is taken after food, the medicine absorption gets slowed down. But even the GIT side effects, also decrease. So after food, if you take the medicine, the absorption is slow. So if you're a stable patient, it's always better to take medicine after food because the faster absorption will not give you any benefit. But if you reduce the GIT side effects, the benefit is more. Now, if the GI motility is more, it means the medicine molecule will come across with new surface area in the GIT. So when the one molecule is getting absorbed from one part, the other molecule will come across with the other area of GIT and that get absorbed from there. So more is the motility, the more is the rate of absorption, the faster is the rate of absorption. Now the first pass metabolism. So if a drug has high first pass metabolism, it means most of the drug get metabolized in liver before it get absorbed. So it means the medicine will reach the plasma in a very less concentration. So more is the first pass metabolism, less is the bioavailability of the drug. Now pH of media is also affected. Like we know that like is absorbed in like media. So please remember guys, acidic drugs are absorbed in acidic media. Basic drugs are absorbed in basic media. So like is absorbed in like media. Now guys, whenever we give medicine by IV route, the medicine bioavailability is almost 100%. So when you give the medicine by IV route, the medicine bioavailability is 100%. Now, after this drug absorption, we have the drug distribution in the body, and the drug distribution is calculated by this parameter, that is volume of distribution. So volume of distribution is calculated when we divide the dose with the plasma concentration. This will give us the exact value of volume of distribution. Now, from this formula, we can say the dose of a drug that is given to a patient, dose of a medicine that is required by a patient for a particular disease, that depends upon two factors. So how much dose is appropriate for a human being? That depends upon two factors, volume of distribution and the plasma concentration. Now, volume of distribution is an individual parameter. Like my volume of distribution is different, your volume of distribution is different. So this volume of distribution depends upon which factors? So this depends upon some physiological factor. So guys, very simple. More is the size of the body, more is the volume of distribution, less is the size of the body, less is the volume of distribution. More the number of compartments present in your body, more is the volume of distribution, less are the number of compartments present in your body, less is the volume of distribution. Like if we talk about pregnant female, obese patient, adult patient, or the patient who has more body surface area. So these patients have more volume of distribution in comparison to their counterparts. Like if I compare pregnant with non-pregnant, obese patient with a lean patient, body surface area which more body surface area with a less body surface area, or if we compare the adult patient with the child patient, these are the human beings who have the more volume distribution, so they required more dose in comparison to their counterparts. The pathological state, when the patient is having the edema, patient is having the liver disease, having the ascites, patient is having the congestive heart failure. Then now here in this case the plasma volume is more, so patient volume of distribution is more. But in patients of dehydration or the fasting, the patient is taking less water, so patient will have the less volume, so volume distribution is low. Now, if a drug is lipid soluble, the medicine can cross the membranes of the body easily. So this medicine can enter in the various organs of the body. So medicine can distribute more. So I will say the medicine volume distribution is more. Now, if the medicine is more plasma protein bound, if a drug is more plasma protein bound, then the size of the drug molecule become big, and now this big size molecules which are protein bound cannot cross the membrane. And when they cannot cross the membranes of the body, they cannot go anywhere. They will be less distributed in the body. So they will not go to any organ. They will remain in the plasma. So their volume of distribution is overall less. Right, guys? So this is the concept of volume of distribution and drug distribution. Now, after this drug distribution, the drug has different type of targets. So drug will go and bind to the different type of targets. So medicine targets we can classify in 4 groups. The receptors is the most common target. Receptor is the most common target of the medicine. So receptors can be present in nucleus. So the nuclear receptors, the examples can be thyroid hormone. So thyroid hormone receptors are the nuclear receptors. Vitamin A receptor is a nuclear receptor. PPAR gamma, PPAR alpha receptors are the nuclear receptors, and the estrogen receptors are also nuclear receptors. Now, cytoplasmic receptors are associated with steroidal drugs. So any drug which is steroid, any of your sex hormone drug, or vitamin D, they have the cytoplasmic receptor. Now we have the membrane receptor having the kinase activity. So membrane receptor having the kinase activity, the mnemonic is PGI love. And for this PGI love, you can remember the prolactin. So prolactin, we have a growth hormone. So we have a prolactin, we have a growth hormone, we have a growth factor, we have insulin. So insulin associated with kinase enzyme activity, growth factor, growth hormone, prolactin, and the leptin. So these are the 4 or 5 examples where the hormones or the drugs have the membrane receptor having the kinase activity. Now, membrane receptor with G protein coupled receptor or G protein activity, this is the most common type of receptor. So this is the most common type of receptor. The shape of the receptor is a 7 helical shape. The shape of the receptor is a 7 helical shape. We also call it serpentine shape. Serpentine means the receptor shape is like a snake. So serpentine shape, 7 helical shape. So we talk about this G protein coupled receptor. Now in this G protein coupled receptor, we have an active protein. We call it G alpha protein. Now this G alpha protein can be of 2 types. This can be G alpha S, G alpha I, and G alpha Q and not. Now G alpha S is stimulatory. This will increase the level of cyclic AMP and can result in stimulatory action. G alpha I is inhibitory. This will decrease the level of cyclic AMP and can result in inhibitory action. Now G alpha Q and not, we call it, this will increase the level of IP3 DAG and can result in action in the body. So these are known as secondary messengers. So these are known as secondary messenger of the G protein coupled receptors. So these are the different type of important targets for your examination point of view. Now, the second important target of the medicine is enzymes. So medicines can go and bind to the various enzymes, and these medicines are enzyme inhibitors. Medicines can inhibit the various enzymes of the body. Now, enzyme inhibition can be of 2 types. This can be irreversible enzyme inhibition, and this can be reversible enzyme inhibition. If we talk about the reversible enzyme inhibition can further be of 2 types. This can be competitive or this can be non-competitive enzyme inhibition. Now guys, in competitive enzyme inhibition, the value of Km will increase, but the value of Vmax remains same. So Vmax remains same, the Km value will increase, but in non-competitive block, the Km value remains almost same, but the Vmax value will decrease. So this is a difference between competitive and the non-competitive block. So 2 important drug targets we people have covered. One is the receptor, second is the enzymes. Now, if we talk about guys, the drug actions in the body. So drug actions we can calculate with the help of this graph. We call it log DRC graph. The shape of this graph you can see here. This is sigmoid shape. So DRC is a sigmoid shape of graph. We call it log DRC. Now here the dose is plotted in logarithm scale. And because the dose is plotted in logarithm scale, we can plot a wide range of dose. So wide range of dose can be plotted. So wide range of dose can be plotted in this graph because logarithm scale is like 0, 10, 100, 1000. It's not 1, 2, 3, 4. It's 0, 10, 100, 1000, 10,000. So wide range of dose can be plotted in a smaller distance. So this is a advantage of using this dose in a logarithm scale. Now the middle part of this graph, you can see the middle part of this graph is a straight line. And because the middle part is a straight line, here in this region, the response of the medicine is directly proportional to the medicine dose. So guys, this is a dose response curve. You can see the log DRC dose response curve. On x-axis, we have taken the dose. On y-axis, we have a response. So in middle part, when we increase the dose on the x-axis, the response will increase in the same extent. So this is the beauty of the straight line. So calculation is very easy to do in this part. Now guys, with the help of this graph, we can calculate 2 very important doses. One is known as LD50. One is known as LD50 and second is known as ED50. Now guys, what is LD50 and ED50? So this is the therapeutic index where we take the ratio of LD50 and ED50. So dose at which 50% of your sample population. So dose at which 50% of your sample population show you the effect that you required, that is known as ED50, and dose at which 50% of the sample population will die, that is known as LD50. So this will show you the death of the sample, like we are doing the animal experiment. So death of the sample, and this will show you the effect in the samples or the animals. So when 50% animals show you the effect, we call it ED50. When 50% animals will die in the experiment, we call that dose is known as LD50. Now, when we divide this dose, this will give us the therapeutic index. And when this therapeutic index is more than 2, we will say the medicine has wide therapeutic index and medicine is safe to use. And when this therapeutic index comes out to be less than 2, we will say that the medicine has narrow therapeutic index and medicine is unsafe to use. So therapeutic index is what? We say that the therapeutic index is the index of drug safety. So therapeutic index is the index of drug safety. This will tell us which drug is safe to use, which drug is unsafe to use. Now, this is the graph which is showing the effect of LD50 and ED50. So this initial part is ED50. So this is the dose. When you give 50% effect, you can see, and this is known as LD50. So LD50 is always higher than the ED50. Right, guys? So this is your ED50 and LD50. Now, the fifth point is, with the help of this graph, we can also compare the drugs. So we can also compare the drugs with the help of this graph. So when you want to compare the drugs, we always compare in terms of potency and efficacy. Now guys, potency means the minimum dose of the drug. It is the minimum dose of the drug that is required to produce a certain response. So minimum dose of the drug that is required to produce a certain response. So minimum dose of the drug that is required to produce a certain response is known as the drug potency. And this is plotted on always on the x-axis. So we always see the position of the DRC on the x-axis. Assume I have 4 medicines with me, A, B, C, and D. So any graph that is on the left side. So any medicine graph is on the left side. So left side DRC means the drug is more potent. So it means that drug is more potent than the medicine which has the graph on the right side. So here the A is most potent, followed by B, then C, then D. This is how we can compare the potency of the medicine. Now, if we talk about the efficacy, efficacy is the maximum response. Efficacy is the maximum response of a drug at any given dose. So whenever we see the maximum response, we know that the response is plotted on the y-axis. So we see the height of the graph. So here the height of the graph is important. So more is the height. So more is the height of DRC, more is the efficacy, less is the height of DRC, less is the efficacy. Like in this graph, if I say we have the 4 medicines, so D is most efficacious, followed by A, then we have C, then we have B. So this is the sequence of the medicines. Now here in this case, C is more efficacious than the B, then A. This is how we can say the more is the height, more is the efficacy, less is the height, less is the efficacy. Now this graph is showing you the tolerance. Like if I increase the dose on the x-axis, initially the response will increase, but gradually the response will start declining. So this is showing you the medicine. The body is getting tolerant to the effect of medicine. Now the slope of DRC is also important. Like we can have the 2 type of slope. Like in the first figure, you can see the steep slope. In second figure, you can see the flat slope. So in a steep slope, whenever you increase the dose, you can see here, whenever you increase the dose of the medicine, the response will drastically increase. Response will increase manifold. So the medicines which have the steep slope, whenever you increase the dose of the medicine effect will increase many folds, and the risk of toxicity is more. But in flat slope, you can see when we increase the dose from this red to blue, you can see the effect will increase only a bit. So here you can say this is a flat slope. Here the risk of toxicity is low on increasing the dose. So here the risk of toxicity is low whenever we increase the dose of the medicine. So this is the beauty of this flat slope. Now with the help of this graph, we can also see the effect of competitive and the non-competitive blocker. So guys, please remember, whenever you see the graph, the drug name is same. Like if you see the previous graph of the efficacy and potency, here the drug name is changing. So whenever the drug name is changing, you always comment upon the drug efficacy and potency, then you can say in terms of drug comparison. But whenever the drug name remain will same. Now you can see in this graph the drug name remains same. So in this case, you can see the shift of the position of the DRC. So here the DRC of the drug A is shifting towards the right side. So we call it right shift of DRC, and this right shift of DRC is a property of a competitive block. So this is showing you the competitive block, and when there is a flattening of DRC, you can see this is a flattening of DRC. This will show you the non-competitive block. So flattening of DRC shows you the non-competitive block. Now, after this drug action, we have a drug metabolism. So drug metabolism will take place in the liver, and you should be knowing the names of liver enzyme inducers and inhibitors. So here the most important point is to know the names of medicines which are liver enzyme inducers and inhibitors. So liver enzyme inducers, the mnemonic is car gas. So medicines which are liver enzyme inducers, the medicines are corticosteroids. We have anti-epileptic drugs. So anti-epileptic drugs except sodium valproate, which is a liver enzyme inhibitor. So most of the anti-epileptics are liver enzyme inducers except sodium valproate, which is a liver enzyme inhibitor. Now rifampicin is one more medicine which is a liver enzyme inducer. Now we have a medicine that is griseofulvin. So we have a medicine griseofulvin. So griseofulvin is a drug which is also a liver enzyme inducer, alcohol, and the one more is the smoke. So these are the things that can induce the liver enzyme. If we talk about the liver enzyme inhibitors, the mnemonic to remember the medicines names are PYQs. So here we have the medicines like the protease inhibitors. So protease inhibitors are the medicines that we can use for HIV, and all the medicines end with the word navir. Like one of the example is ritonavir. So ritonavir is the strongest liver enzyme inhibitor available in the market. Now we have an antibiotic erythromycin. So erythromycin is also a liver enzyme inhibitor. We have a drug like allopurinol. Allopurinol is also a liver enzyme inhibitor. We have antibiotic like ciprofloxacin, clarithromycin. So ciprofloxacin, clarithromycin, clindamycin, chloramphenicol. So all these medicines are liver enzyme inhibitor. So all these antibiotics start from letter C, but not the cephalosporin. So don't include cephalosporin here. Now we have a omeprazole. Omeprazole is also the liver enzyme inhibitor. We have a medicine cimetidine. Cimetidine is also liver enzyme inhibitor, and we have a drug ketoconazole. So ketoconazole, cimetidine, omeprazole, these medicines are liver enzyme inhibitors. Now after this liver metabolism, we have a drug elimination. So if we talk about the drug elimination, so we have a net elimination of the drug. So net elimination of the drug depends upon how much drug is filtered plus how much drug is secreted directly in the PCT minus how much drug is reabsorbed. So how much drug is filtered, that depends upon the kidney blood flow. So more is the kidney blood flow, more is the filtration. Less is the kidney blood flow, less is the filtration. Now filtration also depends upon the medicine plasma protein binding. So if a drug is more plasma protein bound, if a medicine is more plasma protein bound, the size of the molecule become big. So that molecule cannot be filtered out. So filtration is going to be less. Now the medicine secretion. The medicine secretion directly in the tubule. So small, some amount of drug is filtered, some amount of drug is directly secreted in the tubule. This depends upon the presence of some ATP pump. So we have the presence of some ATP pump in the kidney. With the help of this pump, the medicines get secreted. So we have a very important pump present over here. We call it P-glycoprotein pump. So P-glycoprotein pump, which is present in the kidney, this is involved in elimination of many drugs. One of the classical example is digoxin. So this is required for the elimination of digoxin. So we have some medicines which can inhibit this pump, and those medicines can interact with digoxin. So which medicines are inhibitor of this P-glycoprotein pump? The medicine mnemonic is CAVQ. The full form of CAVQ is clarithromycin. So clarithromycin is inhibitor of this pump. We have a medicine amiodarone. Amiodarone is inhibitor of this pump. We have a drug verapamil. So verapamil, erythromycin. So verapamil, erythromycin, quinidine, and one more drug is cyclosporin. So total 6 medicines are there: cyclosporin, clarithromycin, amiodarone, verapamil, erythromycin, quinidine. These medicines are the P-glycoprotein pump inhibitor, and all these medicines can interact with the medicine digoxin. Now, net elimination of the drug from the body depends upon how much drug is filtered, how much drug is secreted, minus how much drug is reabsorbed by the tubule. So how much drug is reabsorbed, that depends upon the lipid solubility. So this depends upon the lipid solubility of the drug. The medicine which is more lipid soluble can easily cross the membrane and can get reabsorbed, and therefore the net elimination is going to be less. It also depends upon the pH of urine, and we know the concept that like is absorbed in like media. So we know this concept of like is absorbed in like media. So like is absorbed in like media. So guys, please remember, when the drug is acidic, urine is acidic, the drug get reabsorbed. But vice versa is also true. When the drug is acidic, urine is alkaline. Like we can make the urine alkaline, so we call it forced alkaline diuresis. this will lead to faster elimination. Forced alkaline diuresis means we can make the urine alkaline. This is required for the faster elimination of the acidic drug. So this is we use for methotrexate toxicity, phenobarbital toxicity, and the aspirin toxicity. So this is the treatment of choice for aspirin toxicity, phenobarbital toxicity, and methotrexate toxicity. So guys, these three medicines are the acidic drugs. These three medicines are the acidic drug, and normally we have the acidic urine. So in acidic drugs placed in acidic urine, the medicines always come back. So if the patient suffers from these medicines toxicity, we have to make urine alkaline, and that is known as forced alkaline diuresis. And this is done by giving sodium bicarbonate to the patient. So sodium bicarbonate is given to a patient to make the urine alkaline, and with the help of that, the medicines get eliminated. Now, in elimination, we have a word plasma clearance. Now, plasma clearance is given by rate of elimination upon the plasma concentration. This is the clearance. Then we have the half-life of the medicine. Half-life of the medicine is given by 0.693 Vd upon clearance, volume distribution upon clearance. And then we have the steady state level, guys. So please remember, guys, steady state level of a drug. Steady state level of the drug is achieved after 4 to 5 half-life. So after 4 to 5 half-life, the medicine rate of elimination becomes rate of absorption. So medicine rate of elimination becomes rate of absorption. So this formula is not much important for you. So just remember, after 4 to 5 half-life, rate of elimination becomes rate of absorption. And then we say that the medicine steady state level is achieved. Now guys, if we talk about loading dose formula is given by volume distribution into plasma concentration. And the maintenance dose formula is given by clearance into plasma concentration. So if the question comes to you, the loading dose depends upon which two parameters? You will mark volume distribution and plasma concentration. Maintenance dose depends upon clearance and plasma concentration. Now, after that, we have a drug discovery, how a new drug is discovered. So guys, first of all, animal studies are done. And then after animal studies, the company will file one application. We call it investigational new drug application. So this is the investigational new drug application the company will file. And in this application, company will take the permission from the government to start the clinical trials. So company will take permission to start the clinical trial. We call it investigational new drug application. Now there are three phases of clinical trial: phase 1, 2, and 3. Now guys, phase 1 clinical trial is known as toxicity studies. We also call it safety studies. So this is known as toxicity studies and the safety studies, where the experiments are done on the human volunteers. So here the experiments are done on the human volunteers, and we try to find out the drug toxicity or the toxic dose of the medicine. Now, phase 2 is known as efficacy studies. This is known as efficacy studies, and this is also known as first in patient trial, because first time the drug is given to patients in phase 2, and we come to know about the medicine therapeutic dose. So first time drug is given to the patient, and we calculate the therapeutic dose of the medicine in phase 2. Now phase 3 is a multicentric trial. So phase 3 is known as multicentric trial. So here the patients are admitted at the multiple centers or multiple locations of the country, and the medicine is given to these patients. This is in phase 3. So phase 3 has the maximum sample size. So multiple locations, patients are admitted. So maximum sample size is noticed in phase 3. Now after the success of phase 3, the company will write one more application to the government. We call it new drug application. Now in this new drug application, company will seek the permission to launch the drug in the market. The company will seek the permission to launch the medicine in the market, and once the company will get a permission, the drug is launched. Now after the drug is launched in the market after phase 3, the company will start the post-marketing surveillance, that is also known as phase 4 clinical trial. So in this post-marketing surveillance, anyone who is taking the drug can report any adverse effect of the drug which is not reported before. So any adverse effect which is not reported or not noticed before, that can be reported in phase 4. And this activity, when we report the side effect to the government that the drug is causing a problem, this activity is also known as pharmacovigilance. So this activity is known as pharmacovigilance. So this is all about the clinical trials, how a drug is discovered, and that is all about this content of general pharmacology. I hope you people have liked it. Thanks for watching it.